Hello, everyone. My name is Andrew Nostrella, Tigmer Internal Medicine resident. Today I'm presenting a case of ADEM. ADEM, also known as post-infectious encephalomyelitis, is an autoimmune demyelinating disease of the brain and spinal cord characterized by rapid and progressive encephalopathy and multifocal neurological deficits. Commonly triggered by viral infections, ADEM is an important consideration for inpatient providers when caring for patients with acute onset encephalopathy, now explained by more common hepatic, uremic, infectious, or neurological causes. Purposes of the case report is to present a case associated with COVID to improve clinical awareness of this illness that can often be easily and quickly managed by cheap medications like IV steroids. This report discusses a 67-year-old female who presented with confusion, vomiting in her sleep, and asymptomatic COVID. This patient had normal neurological function the night before exhibiting rapid and progressive encephalopathy. She was initially considered to be a stroke alert due to having a right side facial droop and dysarthria. A comprehensive workup was performed yielding negative results for any type of infectious, hepatic, uremic, or neurological causes, but had a positive COVID test. The stroke workup was also negative, but brain MRI showed severe confluent periventricular and deep white matter encephalomalacia, suggestive of a inflammatory demyelinating syndrome like ADEM. Due to a negative workup of other causes, suggestive MRI imaging, and positive COVID diagnosis, ADEM was diagnosed, and the patient was started on a 5-day course of IV methylprednisolone 1 gram daily. Radical and rapid clinical improvement was noticed within the first day of initiating the high-dose steroids, and the patient was returned to her baseline neurological function within 3 days and later discharged home after the course. Diagnosing ADEM is a clinical diagnosis of exclusion, usually associated with a preceding infection and suggestive brain MRI findings. Key clinical features, that distinguish ADEM from other disorders are acute and rapid progression of the encephalopathy and multifocal neurological findings. ADEM must also be distinguished from other uncommon causes like multiple sclerosis, neuromyelitis optica, and infectious encephalitis. ADEM is thought to be an autoimmune demyelinating disease of the brain and spinal cord, characterized by rapid and progressive encephalopathy, and also triggered by myelin autoantigens cross-reacting with antiviral antibodies to the pathogen, causing edema and perivenous inflammation and demyelination. 50-75% of adult cases are associated with preceding infection and can follow any number of nonspecific URI or GI illnesses. However, most recently, new cases of ADEM presenting with COVID as primary symptom have occurred, much like our patient today. In conclusion, ADEM is a little-known disease process that could be easily misdiagnosed if not recognized, especially in hospitals without adequate neurology coverage. However, if recognized, may lead to improved clinical outcomes and otherwise difficult to treat patients. And due to the increased number of cases caused by COVID, clinicians should learn how to properly evaluate ADEM, especially in areas without neurology coverage. Due to the rapid and effective first-line treatments with steroids, I propose clinicians add this diagnosis to the differential when approaching patients with unexplained ultramental status. Thank you.